Okay, apologies for the delay, everyone. Welcome to the last session of the WASH in Healthcare Facilities Initiative webinar series. My name is Joanne McGriff, and I'm the Associate Director of the Center for Global Safe Water, Sanitation, and Hygiene at Emory University, also known as the CGSW, as well as Assistant Professor in the Department of Global Health at the Rollins School of Public Health. I am joined today by our learning team, Ms. Lindsay Denny and Cassandra Savino. If you have been with us over the past year, you know our goal has been to connect, share, and promote action among the WASH and healthcare facility community of practice. Also, as you may know, today is our last monthly webinar as the 12-month initiative has come to an end. After this, we will no longer hold monthly webinars. However, the WASH and healthcare facilities initiative will continue, but in a different form. Over the next several months, we will have periodic webinars covering special topics that are important for the continued improvement of WASH and healthcare facilities globally. These topics will derive from the community of practice, technical experts, and other individuals or institutions who are working on the ground in WASH and healthcare facilities. We will also use our current listserv to send updates, announcements, and select resources that will assist the more than 600 members of this list to continue their work. We will continue to post all of our resources on our website at wnhcfaction.org and welcome feedback and comments at our email address, wnhcfaction@emory.edu. So for today, I'm pleased to have speakers from WHO and World Vision who will speak about WASH and quality of care. Before we get started, I'll pass it on to Lindsay Denny for other updates and announcements. Thank you so much.
Thank you, Joanne. And before we get started, we always summarize our guiding principles for selecting topics and speakers for this webinar series. So to begin with, we believe that WASH is a fundamental prerequisite for quality of care within a healthcare facility, and we'll be talking more about that today. Secondly, there cannot be effective infection prevention and control without adequate WASH in healthcare facilities. Thirdly, sustainability should be built into every WASH in healthcare facilities project from the very beginning, no matter the project size. And lastly, WASH in healthcare facilities is not just about addressing issues at individual facilities. Multiple systems, sectors, and stakeholders must work together to see sustainable improvements. So before we pass on to our speakers, I do want to touch on a couple of updates and news and a bit of background on the series. So the series was put together focusing on reaching two of the Sustainable Development Goals, Goal 3, Health and Wellbeing, and Goal 6, Water and Sanitation, because both of these require WASH in healthcare facilities to be achieved. And last year, the UN Secretary General, Antonio Guterres, used the launch of the Water Action Decade to make a call to action on WASH in healthcare facilities, which later the WHO and partners, member states, responded to through a resolution on WASH in healthcare facilities this past May. Through the past year, we've had 11 webinars, including several webinars in French on systems, assessments, implementation, research, costing, and national action. For those of you following along with WASH in healthcare facilities, you may know that last week there was a large event on WASH in healthcare facilities in Zambia, focusing on country action to improve conditions within facilities. The event included country commitments, highlights of regional activities and learning laboratories, and focus on the 8 practical steps. There'll be a report and learning lab outputs to be shared in the next month by WHO and UNICEF. Secondly, this week it was the inaugural UN Patient Safety Day, and multiple events are going on to celebrate that, including in Ghana. The Ghana Health Services and partners are hosting a national patient safety and quality conference, which is focused on infection prevention and control and WASH in healthcare facilities. Lastly, if you are attending the UNC Water and Health Conference this year, which is October 7th through 11th, there'll be side events on Tuesday, October 8th on WASH in healthcare facilities, including one on the JMP report and one on taking action, as well as an informal lunch on Monday the 7th discussing research and learning in the space. And quick note about Zoom, if this is your first time using it, please feel free to introduce yourself in the chat box at any time, ask questions, or make a comment during the presentation or during the live interactive discussion. Please be sure to select all panelists and attendees to make sure that everyone can see your notes. And then during the discussion section, please feel free to raise your hand to show that you have a comment or a question if you'd like to make verbal comments. Please only do so if you have the ability to use a microphone on your computer or mobile device. So we'll go ahead and get started here. This is the final webinar session, Fitting WASH into Quality of Care. And we have two speakers. Ideally, our speaker from Uganda is having a bit of trouble with Wi-Fi, so hopefully she'll be able to join. But we have first Dr. Blerta Maliqi from WHO Geneva, and she's the technical officer coming from a health systems background, who will be talking to us about quality of care and WASH from the global perspective. And then we'll hopefully have Fiona Aber from World Vision Uganda talking about a project-based approach to WASH and quality improvement. So Blerta, I'm going to hand it over to you.
Thank you very much. Can you hear me?
Yes, we can hear you just fine.
Okay, so let me try to start the presentation. And I would ask you, sometime in my presentation, I would ask your help to launch a video for the audience. Okay, so can you see my screen? Okay.
Not yet.
So thank you very much. So thank you very much for this invitation. My name is Blerta Maliqi. I work in WHO in the Department of Maternal, Newborn and Child and Adolescent Health, and I lead the WHO-based Secretariat of the Network for Improving Quality of Care for Maternal, Newborn and Child Health. It is a privilege to be today in this webinar and to share some of the work that we are doing around quality of care and how it relates to WASH, as well as some of the activities that are happening in countries aiming to improve quality of care, which have a direct interface with the efforts that the WASH community is bringing in health facilities and in public health in general, with an aim of improving results for women, children, and people, population at wide. So as WHO, we are working all together towards improving health with a clear objective that is driven by the Sustainable Developmental Goals, especially that on universal health coverage.
Sorry, Blerta, to interrupt you. Did you have slides you wanted to share? We can't see them.
I am showing the slides. Can you see the
I
slides?
can't see them yet. Oh, there we go. Now you're coming through. That's great. Perfect.
Okay, so that's it. So as WHO, we are working all together towards the goal of improving universal health coverage. And it is clearly that universal health coverage cannot be met and it cannot be achieved without quality of care. This is a statement from our Director General that is driving our strategy and policy and is serving to us as a way to clear the path towards addressing quality within this universal health coverage. But first of all, what is quality? I understand that I'm talking to a collective and a community who may not come from the quality of care background. So for us, quality, it is a complicated concept that requires to be unpacked. At the same time, it's something for which we all together can do something. So basically, it's the degree to which health services for individuals and populations increase the likelihood to achieve the desired health outcomes. It has multiple facets and dimensions. However, the bottom line is that health, it is not only utilization of care, and it is utilization of care with quality. That is a statement that came very clearly at the end of last year from the Lancet Commission on High Quality Health Systems. As we move towards implementation, improving quality implies change. It is multidimensional, and it is not the product of one individual alone. It's a product of many individuals and teams of different parts of the systems and service delivery with the right attitude and in the right system. So as we move forward, I would like to mention a few words around the case for quality. It has been quite difficult for the quality of care community to articulate the case. However, last year was a very successful year in terms of bringing the evidence together. 3 reports from WHO, OECD, and World Bank, from the National Academy of Sciences, Engineering, and Medicine, and finally, the Lancet report on global health, one of a series on high-quality health systems. All of them provided the evidence and gave us finally the numbers on what quality means for service delivery. We know that deaths due to poor quality are very high, and they are perhaps even higher than those from non-utilization of services. We know that quality plays a major role across all conditions. Important for us in the maternal, newborn, and child health community to see that almost half of the deaths, maternal deaths, are due to poor quality. And further, about 60% of neonatal deaths are due to poor quality. We know that the provision of care is poor, and I would like just to highlight the evidence that is coming out from the WHO and UNICEF Global Baseline Report, which shows clearly that 1 in 4 facilities lacks basic water, 1 in 5 has no sanitation, 42% lack hand hygiene and at the point of care, and 40% lack systems to segregate waste. It is very difficult to provide quality care in such poor conditions. We know that the patient's experience of care is poor, and that women and children do experience abuse and lack of respectful care and compassion in health services. However, when you think about the conditions in which the care is delivered, perhaps this lack of experience of care becomes more contextualized. As we move forward, I'd like to draw our attention into the quality of care and MNCH. What were the links? How did we establish these links? And for that, I have found a video that the colleagues from WaterAid, I think some of them may be on the call, have developed for Malawi. And I'll kindly ask Lindsay to run that video for us for 2 minutes before I go into how we're approaching quality of care for maternal and child health, and where are our interfaces and joint points with the WASH community. So Lindsay, if you can help me with the video, please go ahead.
Sure, just opening it up now. Let's see, where'd it go? Let me reload that 1 second here. Apologies, we had it working yesterday. There we go.
We saw how the facilities are and the situations that are there. It was very pathetic to notice that the water supply is intermittent, and obviously because of that short supply of water, the hygiene and sanitation aspects of the facilities around here are compromised. The maternity wing where we went to is hosting people on average of 100 women at the time, and here they only have 2 toilets, and you can imagine they have to queue for those toilets.
Walking around the healthcare facility, we have observed a number of things. I think one of some of the disturbing things that we are seeing is how waste management, especially the placenta bits, are being managed at the hospital. So behind me, there's several placenta bits, others are full, and we can see that there is no protection, no fence around the area, but just 70 meters, there is a ward where women who are expectant and awaiting delivery are staying, and they do their cooking and everything. And one of the center bits just behind me, it's open, and there are a lot of houseflies around it, which means that chances of those houseflies finding themselves on food for the women is very high.
It was very difficult last night to see one woman who had come in, and the medical personnel had all been stationed to either deal with an emergency. They were otherwise occupied dealing with equally important patients. And she came in and she was ready to deliver, and unfortunately there was no bed for her. and she actually had to be laid on the floor, and she delivered on the floor, and I couldn't. That was very difficult to come to terms with, and I think it's something that I will take home with me. Just asking myself, really, what is it that we need to do? And it's a challenge, I guess, to myself, especially in my role, to see how best it is that we can mobilize additional resources that will get us towards the change that we actually want to see.
I will continue with my appeal, as I promised earlier on before embarking on this sleepover challenge, that people should join us in terms of fundraising to support this district hospital. My pledge by then was to raise 2 million Malawi budget, but probably with what I have seen today, I would appeal for more support so that we can surpass even the 2 million that we had anticipated to support Cheo District Hospital under this core of the Nation Publications Mother Fund Run.
Thank you, Lindsay. Can I take back the sharing of the screen?
Yep, you can go right ahead.
Thank you. Can you see my screen?
Yes, we can.
Okay. Can you see my presentation screen or the full screen?
We're seeing it in presentation mode.
Okay, thank you. So this is, for us, this is an excellent illustration of the current situation of health facilities that are providing the services for mothers and babies. And it goes even beyond. It does include children and maybe other health facilities in general. So this is where we started our work. It illustrates very well where we started our work and what the challenge was. So why did we move into quality of care for maternal, newborn, and child health? First of all, WHO and partners articulated a very clear vision. We articulated a vision that says every woman, newborn, and child receives quality care, healthcare services throughout the continuum and all levels of care. To move ahead with this vision, we started to unpack what is required. There is a lot of guidance and goodwill out there. However, what we were lacking, it was bringing those different types of guidance, be that clinical care or systems, into one place and providing what we call standards of care. That was articulated in 2 core documents, which are the standards for improving quality of care for maternal newborn health, as well as for children and young adolescents. The standards bring together the provision of care, so what care we give, we provide, the clinical care with the experience of care under a health system. Why this is important for our discussion today? It is important because each of the set of standards includes 8 domains, 8 important areas that need to be tackled for quality to be improved. And one part of those domains you will see there is number 8. It talks to essential physical resources available. And very clearly under this domain, the most important part is WASH. I have taken the liberty to extract a number of the statements that come together with water and sanitation. I will not go through them one by one, but I would like you to have a feeling of what it means for us in maternal, newborn, and child health community to deliver quality care, and what is the requirement, what is a basic requirement for us, at least from a WASH perspective, to deliver on that care. So first of all, the standard, it means that the health facility has an appropriate physical environment with adequate water, sanitation, and energy supplies, as well as all the other inputs for routine maternal newborn care and management complications. And the quality statement talks clearly to water, energy, and sanitation, hand hygiene, and waste disposal, available, functionable, reliable, and safe, and sufficient to meet the needs of staff, women, and their families. So allow me just to go very quickly through what does it mean actually in reality. It means that the facility has a functioning source of safe water located on the premises. It means that the waste bins are leak-proof, covered, and labeled. It means that the facility should have at least 1 functioning hand hygiene station for 10 beds. It has energy infrastructure, the up-to-date protocols for operating and maintaining water, sanitation, and hygiene in facilities. It means that the facility has a sanitation facilities on premises that are usable. Important as we are discussing maternal and newborn. So think about a childbirth department or room or facility, clinic. So in this type of facilities, we'd like to have at least one toilet that meets the need for menstrual hygiene management with the hand washing stations, sufficient trained competent staff who is clear about description of their responsibilities in relation to cleaning and maintaining water and sanitation, funds or resources for rehabilitation, improvement, and maintenance, as well as a preventive risk plan for managing and improving water and sanitation. So those are some basic inputs, so basic requirements which will require a need for quality of care for care to be of quality in the maternal health world. So the video that we just saw, it talks to all these statements and to the challenges that we have in bringing this level of minimum input in the service. The outcome is important to what we are measuring and how we're measuring, and that these outcomes, which are very WASH related, they do relate to the ultimate outcomes. As we move towards the quality of care statements for pediatric care for children, while the overall statement remains the same, there are some characteristics which I'd like to draw. And as a good colleague and friend of mine says, children are not small adults. They have their own requirements, and they become very clear when we start discussing WASH. So while the up-to-date protocols, cleaning, disinfection remains the same, things start to become more different when we discuss source of water, which is for drinking and personal hygiene, but at the same time is a medical intervention. We know that diarrhea is one of the main killers in under 5 children. Formula and ORS depends on the water. Drinking water stations that are low or have a stool for easy reach, we're talking about children and waste bins, the same as for maternal and newborn health. But at the same time, as we move further, again, functioning hand hygiene for 10 beds, but with lower or a stool to reach taps. Has baths and other hygiene facilities on premises which are adapted to young children, and of course segregated by sex for older children and carriers, especially as we start discussing adolescent health. Similar for the sanitation facilities, which are adapted for the needs of children and young adolescents, and more further on as we move to sufficient trained staff, the security and the risk management plan, the adequate laundry facilities, many children that go with their caregivers, with their family members. So it is not about the child only, but the environment in which a child is taken care of in the facilities, and professionals and carriers who are trained in good hygiene and regular washing. So what does it mean? It means that caregivers and children, they do have a good results, but at the same time, we do have a number of milestones in between. So we'd like that the health facilities that are providing pediatric care, child care, that do not have breakdowns in water supplies, that the soap and hand disinfectants are available, and the waste management is done appropriately. Outcomes, so there is a satisfaction part as well as the for both the caregiver and the child, as well as for the staff. And finally, we would like to know that the clear principles or the key principles of IPC are respected. So I gave only a feel of what is coming out into, or what is in the standards, and that is to say that we will not be able, for the MNCH community, we are not able to reach our objectives and goals if WASH is not available, is not present and fully functionally in health facilities and beyond. So what does it mean as we move towards action? It is clear that achieving quality care everywhere for every woman and child is very challenging. We will need to address both aspects of infrastructure and development, competency, and so on. At the same time, we know that we do not have the answers to all the questions on how do we improve and maintain levels of improvement throughout in facilities. So to this end, we did countries, 11 countries came together a year and a half ago, together with our partners from developmental partners, implementing partners, and donors, and they established what is called the Network for Improving Quality of Care for Maternal, Newborn, and Child Health. And you can see the names of the countries listed in the slides. So what is it that brought these countries together? It brought a vision that says that every pregnant woman and newborn infant receives quality care throughout pregnancy and childbirth, as well as postnatal period and growing, with equity and dignity. So it's a quality, equity, and dignity. And clearly, we do have a goal, reducing maternal and newborn health deaths by 50% and improving experience of care within 5 years. So the clock is ticking. The results should be in place before the end of 2022. We have started to see some results, and those results are a part of the implementation of this joint vision that is pursuing 4 key strategic objectives that go towards leadership, action, learning, and accountability. So allow me only to take a few minutes to explain what these 4 strategic objectives that the member countries develop themselves mean. So let's start from the very first point, so the goal. Everyone agreed that we would like to improve quality of care and to reduce mortality, improve experience of care. The way that leads us there, it is that we need to improve quality of care, and quality is improved at the point of delivery, at the point where the patient meets the provider. That means that we'll need and require the right staff, enabled to deliver the right care in the right way at the right time in the right system. As usual, we will require policy strategies and structures to support this implementation. We will require standards and quality interventions that can improve the ability of the system to provide quality of care. We will require facilities that are enabled to do their work well in order for them not to do harm, patients, families, and communities that are engaged and empowered, and then linked to the right staff. So moving now from this long list of needs and requirements into the goal, we do need to look at how do we bring these pieces together. And that way, the only way that we have found so far with 11 countries to bring these pieces together is through the road of quality improvement. That means on-site support, meaning quality improvement in all facilities, teams that are engaged in continuous problem identification and problem solving with adequate support to the issues that they are facing, learning, exchanging our knowledge and solutions among different places, facilities, districts, and countries, measurement, community engagement, and of course, program management. In the real life, things are a bit more simple. It means that we need to have a national strategy and policy in place that talks to quality of care, that brings all the different pieces that contribute to quality of care together. It requires an adaptation of the standards of care. And you just saw the illustration that if all countries adopt the maternal and newborn child health standard, aiming to improve results for maternal and child health, they have to tackle all issues in relation to maternal and child health, including WASH. They have to identify what are the first aims that they would like to improve, to build a partnership and develop their plans, and of course to move into the implementation. An implementation that is clearly driven by a quality improvement that has measurement at heart, but at the same time is driven by the learning and exchanges of ideas. So as I mentioned, there are 11 countries with Kenya. 10 countries started at the same time. This is the progress that they have made in the last year and a half. So all these countries have now national leadership for quality in place. That means that they have established technical working groups or committees that bring all the stakeholders. They should bring the WASH stakeholders together around the same table to discuss and agree on their strategy. They have developed their roadmaps. They have identified the priority areas and interventions that they would like to focus. Some of the countries have identified interventions in relation to improving washing facilities. And then they have moved into action. They have moved into identifying their first districts and where they would start. They are calling them learning districts. It's not about testing. It's about implementation and learning what works and doesn't work. They are implementing. And now we're seeing, as you go further towards the dashboard, you'll see that the green becomes more orange, yellow, or no information. And that is because we are at the moment in which the monitoring is actively being pursued and learning is starting. So this was done in March, and not much information was in place. So this is a very active platform. We have colleagues from different ends of the public health spectrum, not only for maternal, newborn, and child health. We have a lot of colleagues from health systems. We are working hand on hand with the folks in the health systems to establish the basis for a national quality strategy and policy. And as we go forward, all these countries now have these active platforms around quality of care that are a window of opportunity for connecting dots and achieving common results. So if I go and think how could the WASH community engage in the network, become a part of a national district facility or technical working group, engage with the learning districts that are implementing quality improvement, link WASH assessments and responses with quality of care assessments and responses, and more importantly, report on common results. There are a number of resources that are available. You will receive them at the end of this webinar. At the same time, I wanted to draw your attention on the Global Health Laboratory that is managed by WHO that contains a number of specific resources around WASH and how WASH can be used as an entry point or leveraged to achieve the broader UHC results. So I'll stop here and thank you very much.
Thank you so much, Blerta. That was a fantastic summary of how we see WASH fitting into the quality of care from the global perspective and the work that WHO is engaging in, particularly with the network. Before we get into questions, as I'm sure there are around your presentation, I'm going to see if Fiona, if your microphone is working. Can you hear us, Fiona?
Oh yes, I can hear you.
Fantastic. Well, if Blerta, you could stop sharing your screen, and we will have Fiona. You could just put your slides up, and we'll have you go ahead. As you do that, for everyone's background, Fiona, Aber Fiona is a hygiene and sanitation officer with World Vision Uganda, and she's worked in the WASH sector in both humanitarian and development contexts for 9 years. She has worked with WHO, Concern Worldwide, International Medical Corps, Action Africa Help, and now, of course, World Vision. So, Fiona, we're excited to hear from you about your project experience on WASH and healthcare facilities with quality of care.
Okay, thank you so much, Lindsay. Good morning, good afternoon. Yes, so like she said, I'm going to make a presentation on a project that we've been implementing in Uganda, specifically looking at improving quality of care with a lens for maternal, newborn, and child health in healthcare facilities. So, hello?
You want to put yourself into presentation mode, then we can see the full slides.
Oh, sorry.
Perfect.
Is that okay now? Okay, okay, great. Yes. So according to WHO, first of all, I wanted to make us have an understanding of what quality of care is. So according to WHO, it's the extent to which healthcare services provided to individuals and then population are able to improve desired health outcomes. And for this to happen, then the services at the healthcare facilities have to be safe, they have to be effective, timely, efficient, equitable, and then people-centered. So first of all, looking at the project we're currently doing, our entry point was an assessment that was done by Emory University in partnership with Care International and World Vision, where we went ahead and we had an assessment of 52 healthcare facilities in the district where we're working now to give us a baseline of what the indicators were with regards to water, sanitation, and hygiene in this healthcare facilities. And then we also went ahead and did an assessment of the 5S methodology, which I hope we are familiar with. And then we also did a quality of care improvement assessment in these same healthcare facilities. And what we ensured we did was that we engaged all the healthcare facility staff, that is both the environmental health auxiliary staff and then the clinicians, to ensure that there was ownership and the ability for every individual to do their part. And like the first presenter said, that quality of care is a multidimensional initiative. So at the end of the day, we realized that for us to be able to deliver, we had to bring all stakeholders on board. Yes, also, like I said earlier, in our programming, we are currently implementing a baby wash project. So what I'm going to present right now is basically the healthcare facility piece, but we also have an equally large community-based component. Yes, so baby wash looks at improving on the welfare of a child for the first 1,000 days of its life. That is from the time the child is conceived and until the child is 2 years old. Of course, with a special lens for maternal, newborn, and child health, nutrition, ECD, and then not forgetting water, sanitation, and hygiene. So in these interventions, also, we look at both infrastructure development and behavior change, and still with a special interest for infection prevention and control. Yes, so so like I said earlier, we ensure that we work through the existing government structures within these healthcare facilities to ensure ownership, and then them being able to sustain the behaviors once they're rolled out. So our interventions are around infrastructure development, that is both in water systems and then sanitation. We're also looking at leadership and governance in these healthcare facilities. We're looking at advocacy. We're looking at the general infection prevention and control, broken down into waste management, sterilization and disinfection, personal protective equipment usage, hand washing at critical moments, and then of course doing this through the 5S, and then continuous quality improvements. So if you look at our infrastructure development, we have done a lot of water investments in healthcare facilities, and we have specifically done pipe water systems and ensured that we have clean water supplied at every point of care. If also you refer to the first presenter, she raised that an issue that infrastructure development is a very key component in improving quality of care. At the end of the day, we cannot say we are providing quality of care in healthcare facilities if we do not have the supporting infrastructure. So, and one of them being water. So we've ensured that we have water supply in the labor suites, in the laboratories, dispensary, treatment rooms, ANC, postnatal care units, in latrines and in kitchens. So you can see a pictorial of a midwife in a labor suit, and then a mother doing hand washing after delivery. And then these are pictures of a sample of 2 of the production wells we did in targeting healthcare facilities. So also with regards to providing water in healthcare facilities, we've also been deliberate to ensure that we're monitoring the quality of the water supplied in healthcare facilities, and of course to ensure compliance with WHO standards. And then we've also gone ahead to be more deliberate to ensure that we have an extra effort when it comes to the drinking water being supplied. You know, in the hospital, people have to drink water to take their medicines, yeah? So at the end of the day, we still ensure that the water that they're going to use for these is of a quality that is worth drinking, and what you're promoting is filtration. Then when it comes to sanitation infrastructure, we've ensured that we promote waste segregation through provision of coded bins. I know in Uganda currently, the government is also supplying healthcare facilities with coded bins, but as World Vision, we've gone ahead to also supporting that to ensure that the bins of the required bins are provided, and then we promote waste sorting to ensure that the right bin is put in the right the right waste is disposed of in the right bin. And then we've also gone ahead to ensure that we've constructed appropriate waste management facilities for final disposal of the waste, ranging from placenta pits, incinerators, ash pits, sharp pits, and then compost pits. Yeah, so that at least within the healthcare facilities, the waste can be managed right from the beginning until the final disposal. And then we've also done construction of latrines, which first of all have to be disability inclusive, because we know that under the standards that are supposed to be observed in healthcare facilities, latrines first of all have to be menstrual hygiene management friendly, disability inclusive, and then we have also put into consideration the patient stance ratio of 1:20, and also we've gone ahead to ensure that staff latrines are separated from the patient's latrines. Yes. And then we've also ensured that birth shelters are constructed within maternity units, both outside and then externally for caregivers to these mothers who have come to deliver. Also within our project, besides the infrastructure development, we've gone ahead because we noticed that providing infrastructure is not good enough. Then there has to be a structure within the healthcare facility that is able to support continuous operation and maintenance of this infrastructure. So we've gone ahead, still following the guidelines from the Ministry of Health in Uganda, to ensure that we have functional health unit management committees, which is about 5 to 7 member committee, which has both the healthcare staff within the hospital and then the community responsible community members with high integrity be sitting in this committee. We've built their capacities in their roles and responsibilities with regards to IPC, and then also maintaining the WASH investments that are brought in these healthcare facilities. And we've also engaged them to ensure that they meet regularly and they're able to monitor the performance of the healthcare facilities. Other than that, we also realized that within our setup in Uganda, there are certain things that we realized that we needed the communities to be empowered to be able to demand for what is rightfully, what is rightful to them. So as World Vision, we have an approach called the Citizen Voice and Action, which is an evidence-based social accountability model that operationalizes and strengthens relationships of direct accountability among citizens, policymakers, and service providers. So at the end of the day, through CVA, the CVA approach, we've been able to empower communities to be aware of what to expect within the healthcare facilities per se, in terms of washing healthcare facilities. So this approach operates in such a way that there is a working group, which are citizens or users of a facility, that are empowered on what they should expect or what must be available in the healthcare facilities, and they in turn are able to hold the healthcare service providers accountable to ensure that everything else that is supposed to be in place is in place, and whatever is beyond the healthcare facility management is escalated to the sub-county leadership, and what is beyond the county leadership is forwarded to the district, and it goes on until the highest level of authority. So at the end of the day, what we're looking at here is to ensure that the communities are able to demand and push for the infrastructure and the investments in these healthcare facilities to be sustained. So it's a step-by-step approach. I won't go into the details. And then at the heart of everything that we do in our project, besides the infrastructure development and and working with leadership and ensuring that there's advocacy through the community to ensure that the rightful infrastructure or the right behaviors are being practiced by the healthcare facility staff, we also have the infection prevention and control interventions that we're doing. And here we are looking at the key components of infection prevention and control. First of all, starting with, of course, ensuring that the right equipment are supplied, and then capacities are built on usage. And then we also provide guidelines, updated guidelines. I think my earlier presenter also talked about providing protocols and guidelines for healthcare facility staff to be able to work through and support them in their work. And then we've also ensured that we do routine monitoring of these healthcare facility staff. So the areas within IPC that we're capitalizing on is still hand hygiene at critical points of care, sterilization and disinfection, ensuring usage and availability of personal protective equipment. This is for healthcare staff. And then finally, waste management. Yes, so I also wanted to talk about how we are doing quality improvement within these healthcare facilities. So within our structure as Uganda, we have a well-streamlined structure of quality improvement committees, right from national level to regional level to district level, sub-county, county, and down to the healthcare facilities. So within our project, we are currently operating in health centers level 3 and level 4. So within these health centers, we have quality improvement committees which comprise of about 7 members. And these 7 members all are departmental heads in different departments, such as the the person, head of department for MNCH, OPD, IPD, laboratory. And so these individuals, together with the in-charge, are the ones who form the Quality Improvement Committee. But again, in each of their departments, they have working groups which we call the Work Improvement Groups, or the WITs. Now, these Work Improvement Groups are the ones that are tasked, they're the ones that are held responsible for ensuring that quality of care is as required. So if you in our structure as Uganda, the Quality Improvement Committee stops at the Quality Improvement Committee, like I said, is from national level up to the lowest level of health centers. But within the health center 3 is where most of our interventions are, and that's the level where childbirth is conducted. We deliberately decided to incorporate the infection prevention and control focal person into the Quality Improvement Committee to ensure that each time the Quality Improvement Committee does their monitoring of interventions, we ensure that infection and prevention control related activities are also incorporated and then turned into projects, and then over time they are monitored to ensure that they are followed up. But one thing I wanted to stress is that above with all this that we do under quality improvement, our mother approach is the 5S, which I believe that we could all be familiar with. 5S is an approach that looks at improving and organizing work environment for better service delivery. So the 5 S's, of course, the first S being to sort, which looks at arranging things in order, putting aside whatever is not required. And then setting is arranging them in order. Third one, the shining, looks at ensuring that there is proper hygiene within the health centers, and then standardizing, and then finally sustaining the status. So in our Ugandan context, the government realized that if we are going to promote the 5S, leadership is a very key component. So at the end of it all, in Uganda, we call it sort, set, shine, standardize, and then we say leadership. Of course, leadership here comes in to enable the sustainability. So we've also gone ahead to do an assessment, a 5S assessment in healthcare facilities, and which critical gaps that were identified were converted into 5S projects or actions, and which actions were over time being monitored, and currently we are registering successes. So I want to give you an example of a typical 5S project. One issue that was identified was improper segregation of waste, and the actions within this project that were raised were continuous medical education on waste segregation, provision of waste bins at critical points of care, monitoring usage of waste bins 3 times a day, weekly appraisals of units in segregation, and then giving daily and weekly feedback. And this was planned to be done in 3 weeks, and the person in charge was the in-charge or the IPC focal person. Now, this responsible person then at the end of the day gives these reports to the Quality Improvement Committee each time there is a meeting. Yes, so at the end of the day, again, continuous implementation of the 5S leads to continuous quality improvement. Of course, quality improvement in terms of care, and with repeated with continuous quality improvement at the end of the day, through all the organization processes, we are able to achieve total quality improvement. So I also want to talk about the pitfalls in quality improvement, one of which is that whoever may want to do something similar or do a similar project in terms of quality improvement, especially looking at MNCH, one of the core things that should not be forgotten or should not be neglected is the issue of ensuring that the desired infrastructure is put in place. When I talk of desired infrastructure, I mean generally the sanitation infrastructure, ensuring that there's running water in these healthcare facilities, and then generally the shelter of the wards have to be have to be in good shape, because at the end of the day, if you say you're going to promote quality of care, if you don't have the right infrastructure, which is actually the biggest challenge we have right now in the health centers almost across the country. So infrastructure is one of the biggest challenges. And then secondly, competing priorities. You know that in healthcare facilities, you have, at the end of the day, the interventions are targeting the few healthcare staff within these healthcare facilities. So at the end of the day, there are so many conflicting priorities that can come in. You may have an HIV project coming in, you may have, another nature project coming in. So at the end of the day, it is that can be a pitfall if it's not well managed within the implementing partners. So one final thing I want to talk about is that WASH is a very paramount. It's a very paramount sector when it comes to improving quality of care within healthcare facilities, because if there is no proper WASH within the healthcare facilities, then the risk of nosocomial diseases are very high, and at the end of the day, quality improvement is compromised. So thank you so much.
Thank you so much for that overview of your work, Fiona, and really exciting to see how you all have taken a quality of improvement approach to this and seeing how we can apply the concepts that Blerta was talking about. We have time for just about 1 or 2 questions here. So I am going to first bring a question from Maggie Montgomery from WHO, and this is directed towards Blerta, though, Fiona, if you have any thoughts. Maggie asks, can you speak to some of the notable successes and challenges within the learning districts? How are learnings being extended and applied at the national level? And what actions would you recommend that WASH actors take to engage and support this work? I know you talked about this a bit, Blerta, but if you have further thoughts.
Well, so maybe I can answer for the registered successes.
Start with what the learning district is. So each country has identified a starting point. Where do they start with the quality improvement and quality of care? The agreement is that they have chosen those districts or regions that are more representative, that are not the best.
Blerta, can you hear us?
They have identified initial learning facilities, which are normally a district hospital or an immediate level after the under a district hospital. The main, I would say, the most.
Blerta, we're losing you a little bit. I can't hear you.
In a year of implementation, we have seen improvement in processes and care practices, improvements in relation to respectful care. We are now starting to see
Blerta, you're coming in and out, so I wonder if it would be better if we actually got a written response for you on this one, just because we can't fully hear your response to the question.
And we are seeing better results or faster results in newborn survival. So this is the good story that is coming out. The challenge is that, first of all, everybody wants to engage immediately from the very beginning.
Blerta, we've lost you again there.
Change as an entry point to further and long-term. Okay, can you hear me? I do lose you from time to time as well, so I'm not sure if it's my end. So no, the biggest challenge is
All right, Blerta, we'll have to get a written response from you on that one. I think I've lost you here, and it keeps cutting out when you're saying the most important response to this question. So, yeah, Blerta, we lost you on most of that. If we could get a written response on you, I think that would be really.
I'll do that.
Definitely.
So please, WASH colleagues, link up with the learning districts. That would be the most important piece on the way.
Okay. Learning districts connections. We'll definitely ensure that that's part of the summary, and we'll get more information from Blerta on that. I'm going to ask one more question before we close here, and that question will be for Fiona. Fiona, could you talk a bit about water quality monitoring? What were you measuring, and who was doing it? What actions were taken if water quality was poor?
Okay, thank you. With water quality, we've been doing mainly the microbiological and the physical parameters. That is for the routine water quality testing. But as the policy states, when a water source is constructed, all the parameters have to be measured. That is the chemical, the physical, and then the microbiological. So with the routine monitoring that we've been doing on a quarterly basis, we've been monitoring mainly the microbacteriological and then the physical. Now, each time a water source is found probably not safe, which I think we just had one case in a healthcare facility. What we did was to go ahead and do chlorine dosing, and that was able to sort the issue. And besides the chlorine dosing, we also went ahead to do sanitary risk assessment to find out if there were any opportunities that were leading to this contamination happening. But at the end of the day, yes, like I said, we had to respond by doing chlorine dosing. But also besides the chlorine dosing, like I already told you earlier, we're also promoting filtration. Much as we know that the quality of the water we are providing within the healthcare facilities is safe water, we've gone ahead to have as an additional provision of doing filtration to ensure that the water that is going to be used for drinking is even safer than the one that is being supplied directly from the system. Thank you.
Fantastic. Thank you, Fiona. And thank you, Fiona and Blerta, for your presentation today. It was great to hear both a global approach and a project perspective on fitting WASH into quality of care. So we'll wrap up now. And for those questions that didn't get responses and unfortunately unable to hear Blerta's response, we'll make sure we get written responses from our presenters that we share with you all within the summary documents. So Cassandra, I'll hand it over to you to close.
Thank you everyone for participating in this month's webinar, and thank you again to Blerta and Fiona for your wonderful presentations and comments. So we will leave the chat box open for a few more minutes. Please feel free to post any additional questions you may have. As always, today's recording, slides, and a summary document will be available within the next 2 weeks at winhcfaction.org. We will continue to share important resources, learnings, and opportunities through the listserv, and plan to hold periodic webinars and online meetings as the need arises. Thank you so much for your participation today, and we appreciate your support and participation over the past year.
Thanks again all, and have a great rest of your day.